right now, across the globe, roughly 60% of menopausal women are experiencing these just agonizing, life-altering pelvic symptoms.
Yes, it's a huge number.
Right, we are talking about chronic pain, severe burning, and this unyielding discomfort that makes simply sitting in a chair or like getting a good night's sleep feel basically impossible.
Absolutely.
And yet, out of that massive population, only 7% are receiving the actual correct medical treatment. I mean, and think about that gap. Millions of people are suffering in absolute silence, they're normalizing their own pain, or just cycling through endless drugstore creams because the medical system fundamentally struggles to, talk about and correctly identify what is actually happening.
It really is a staggering failure of diagnostics.
Mm,
And the tragedy is that, well, in the vast majority of these cases, the suffering is entirely treatable.
exactly.
Like the barrier isn't a lack of medicine. The barrier is this pervasive diagnostic blur between two highly prevalent conditions that present with very similar symptoms, but they require radically different approaches.
And that is the core of our mission for you today. We have this formidable stack of sources on the table. A really comprehensive collection of updated clinical guidelines, NHS patient leaflets, deep dive dermatology and gynecology textbooks, and some frontline medical clinic reports.
A lot of heavy reading.
So much reading. But we are going to take all of this data and untangle the two conditions at the center of this huge medical blind spot. So, vaginal atrophy, which modern medicine now broadly categorizes as genitourinary syndrome of menopause, or GSM,
Right.
and lichen sclerosus, which is commonly abbreviated as LS.
Yeah, these are two incredibly common conditions that just fundamentally alter a person's day-to-day life.
Yeah.
Their intimate relationships, their mental health, yet they are consistently confused, occasionally even by seasoned medical professionals.
Which is wild. So whether you are trying to navigate your own health, maybe looking out for a partner, a mother, a friend, or you just simply find medical mysteries fascinating,
Yeah.
understanding the divergence between these two is critical. Because so many patients spend years misdiagnosing themselves with stubborn thrush, just assuming they have to live with the pain of getting older. But our sources map out a very clear way out of that cycle, provided you know which underlying mechanism you are actually fighting. Okay, let's unpack this.
Yeah, let's do it. So to pull these two apart, we first have to look past the outward complaints of pain and really dive into the microscopic root causes. Because biologically speaking, vaginal atrophy and lichen sclerosus, they originate from entirely different physiological universes.
Right. Going through the clinical guidelines, a very distinct contrast emerges. So imagine vaginal atrophy is like a historically lush, thriving garden. The ecosystem is perfectly balanced, but then the municipal water supply is completely shut off.
It's gone.
Exactly. The soil turns to dust, the roots dry out, the plants thin out and become incredibly brittle.
Mhm.
Nothing is actively attacking the garden, right? It is simply collapsing from a severe lack of vital nourishment.
That captures the mechanism perfectly.
Yeah.
Atrophy, or GSM, is fundamentally a state of profound hormonal drought. It's driven by the sudden or even gradual disappearance of estrogen. We typically associate this with menopause, right? When ovarian function winds down and estrogen levels naturally plummet.
Right, because estrogen is like the water.
Exactly. Estrogen is heavily utilized by the tissues of the pelvic region to remain lubricated, thick, elastic, highly vascularized. When that hormone just vanishes, the tissue physically atrophies. Like it literally shrinks, thins, and loses its structural integrity.
But the sources are also quick to point out that menopause isn't the only trigger for this drought, right? It's kind of a biological math equation. No estrogen equals atrophy.
Yeah, exactly.
So this can happen postpartum, especially during extended periods of breastfeeding, which suppresses estrogen, or abruptly after the surgical removal of the ovaries, or even as a byproduct of certain aggressive cancer treatment.
Right, the trigger can vary, but the downstream effect, that withdrawal of the hormone, is identical. Now, contrast that passive withering with lichen sclerosus. If atrophy is a garden losing its water supply, LS is a completely different scenario. The water is running fine. Instead, the building's own security and maintenance team has been fed bad intel. They suddenly perceive the healthy structure as an active threat, so they begin frantically tearing down the walls and boarding up the doors and windows with heavy, rigid cement to trap the perceived invader.
Wow. A rogue biological maintenance crew. That perfectly frames the autoimmune nature of this. And The dermatology textbooks get incredibly specific about what that crew is actually attacking,
They
right?
do, yeah.
Like, the prevailing consensus is that the immune system creates autoantibodies designed to seek out and destroy something called extracellular matrix protein 1, or ECM1.
Right. And to understand why that matters, we have to look at what ECM1 actually does.
Yeah.
It is essentially the biological mortar that holds the structural scaffolding of the skin, the dermis, together.
It's the glue.
Exactly. It regulates collagen production, keeps blood vessels stable, so when the immune system releases antibodies to dissolve that mortar, the skin's architecture begins to collapse.
And the body just panics.
Yes, the body panics at this structural failure and sends in an extreme inflammatory response to patch the holes.
Mm.
But it patches them with dense, rigid, fibrotic scar tissue.
It's an active, relentless, friendly fire situation. And because the core drivers are so distinct, a systemic hormone absence versus a localized autoimmune attack, the demographics of who gets hit by these look totally different on a population graph.
Oh, entirely different. We see a very distinct split.
Hmm.
Because atrophy relies on the withdrawal of estrogen, it's almost entirely relegated to postmenopausal populations, or those specific postpartum or surgical groups we mentioned.
Right.
But lichen sclerosus, being an autoimmune inflammatory disease, operates on a completely different timeline. We see a major spike in postmenopausal women, yes, but we also see a massive distinct peak in prepubertal girls.
That is a staggering detail from the medical literature. Young children dealing with a severe localized autoimmune response. And the texts also note that LS doesn't exclusively target female anatomy, right?
No, it absolutely crosses gender lines. In male patients, it primarily targets the foreskin and the glands of the penis, heavily skewing toward uncircumcised boys and men.
Oh, wow.
Historically, this was called balanitis serotica obliterans, but modern dermatology has sort of aligned it under the umbrella of penile lichen sclerosus, recognizing it as the exact same autoimmune mechanism.
Right. But returning to female pelvic health, the most complex scenario outlined in the guidelines is the overlap.
Yes.
What's fascinating here is that if you are a postmenopausal woman, simply by virtue of your age and your plummeting estrogen, your garden is drying out.
Right.
But you can simultaneously develop that rogue immune response. You can have the hormone drought and the autoimmune scarring happening in the exact same region at the exact same time.
And the clinical presentation becomes incredibly convoluted when they overlap, which is why untangling the geography of the symptoms is the physician's most powerful diagnostic tool.
But wait, if one is an internal hormone issue and the other is an external skin attack, why are doctors actually confusing these two? Shouldn't it be instantly obvious to anyone with a medical degree looking at the patient?
I mean, in a perfect clinical environment with unlimited time, sure, perhaps, but consider the reality of modern medicine.
Right, time is money.
Exactly. You have a patient in extreme distress who might have waited a year to build the courage to bring this up. They secure a rushed 10-minute appointment. They report a generalized pelvic burning and pain.
And the doctor just rushes it.
The physician, mindful of the ticking clock, might prescribe a broad-spectrum treatment or conduct a very brief visual exam. Without a meticulous, mapped-out physical examination, the specific geography is easily blurred.
And the sources provide a very rigid map for how these conditions behave geographically. They set up camp in radically different territories. Atrophy is fundamentally an inside job. It aggressively targets the internal vaginal canal and heavily impacts the urinary tract, specifically the urethra and the bladder trigone.
And that's because the concentration of estrogen receptors dictates that internal mapping. The internal mucosa and the urinary tract possess the highest density of these receptors.
Ah, that makes sense.
So the moment the systemic estrogen supply dries up, those internal tissues are the very first to sound the alarm and begin the process of thinning and drying.
Whereas lichen sclerosus operates entirely on the outside. It targets the vulva and the perianal skin around the back passage. The dermatology texts describe a highly specific figure of 8 pattern that the inflammation often forms, looping around the front and the back.
Right, and the clinical guidelines offer a hard, unbreakable rule regarding this geography. Lichen sclerosus never affects the internal vaginal mucosa.
Never.
Never. It is biologically restricted from that internal tissue. If a physician observes inflammation, thinning, or damage deep inside the vaginal canal, they could definitively rule out LS for that specific internal tissue.
Wow. Okay, so understanding that clear division inside versus outside is the skeleton key for decoding the radically different daily realities patients face. The lived experience of a hormonal drought feels very different from an autoimmune scarring event.
If we connect this to the bigger picture, the divergence in symptoms is where the real devastation of these conditions becomes apparent.
Yeah.
Let's look at the cascade of failures triggered by vaginal atrophy.
Right.
The primary patient complaints are profound dryness, a persistent burning sensation, deeply painful intercourse, and a whole host of urinary issues, urgency, frequency, and recurrent UTIs.
Here's where it gets really interesting. The textbooks dive into the microscopic why behind those specific symptoms, and it's a fascinating look at how delicate our internal ecosystems are.
It really is.
Without estrogen, the tissue physically thins out. It loses its natural folds, the rugae, and becomes so fragile that doctors often observe petechia, those tiny red microhemorrhages where the skin has simply bled from basic friction. But the real chaos happens with the bacteria, doesn't it?
Oh, completely. The bacterial collapse is the hidden engine of the pain. See, healthy vaginal tissue is fueled by estrogen to produce glycogen.
Right, sugar, basically.
Exactly. Glycogen is the primary food source for a specific family of protective bacteria called lactobacilli. These bacteria consume the glycogen and produce lactic acid as a byproduct.
And the acid is good.
Very good. That lactic acid maintains a low acidic vaginal pH, generally under 4.5.
So it's an invisible, self-regulating shield against infection?
Precisely. But the estrogen drought cuts the fuel line. No estrogen means no glycogen. The lactobacilli starve and die off in massive numbers.
Wow.
Without the lactic acid they produce, the pH of the environment spikes, becoming alkaline. And the moment that environment turns alkaline, the protective shield is gone.
So pathogenic bacteria just flood in.
Yes, leading to the chronic burning, the persistent inflammation, and the endless cycle of urinary tract infections that characterize severe GSM. It is a total systemic ecosystem collapse.
It makes complete sense why that would feel like unrelenting burning and pain. Now, if we pivot to the symptoms of lichen sclerosus, the patient experience shifts dramatically. The defining hallmark of LS isn't just pain, it is a maddening, agonizing itch.
Yeah, the texts describe an intense, unscratchable pruritus that almost always amplifies at night. It's severe enough to consistently wake patients from a dead sleep.
I can't even imagine.
The psychological toll of that chronic sleep deprivation, combined with unrelenting daytime discomfort, is profound.
And visually, the rogue immune crew leaves a very different footprint than the pale thinning of atrophy. The external skin develops shiny porcelain-white plaques. The medical literature repeatedly uses the descriptor crinkled like cigarette paper to explain how the texture of the skin fundamentally transforms.
But the most dangerous aspect of lichen sclerosus, and the reason early diagnosis is so critical, is the structural damage caused by that cement-like scar tissue.
Right.
Because the inflammation is chronic, the body's repair mechanism goes into overdrive. It begins fusing tissues together.
The clinical descriptions of this fusing are alarming. I mean, we are talking about irreversible architectural changes to the anatomy. The scar tissue can literally meld the inner lips together.
Yeah.
It can grow over and completely bury the clitoris beneath the thick hood of fibrosis, and it can severely narrow the external entrance, making any kind of penetration physically impossible. Atrophy thins the skin and makes it fragile, but it does not aggressively remodel and fuse the anatomy the way the autoimmune inflammation of LS does.
No, not at all. The physical remodeling is unique to the inflammatory nature of lichen sclerosus. And this brings us to a massive systemic problem in how patients navigate these symptoms before they ever see a specialist. The psychological and financial toll of misdiagnosis.
Because if you develop an intense localized itch and burning, the immediate culturally ingrained assumption is a yeast infection or a stubborn case of thrush.
Exactly.
You don't assume your immune system is attacking your ECM1 proteins or that your internal lactobacilli ecosystem has collapsed due to glycogen starvation.
No, you assume the most common, most advertised culprit. Patients go straight to the pharmacy and purchase over-the-counter antifungal creams.
Right. They just grab Monistat or whatever.
Yeah. But the clinical data is definitive. An antifungal will do absolutely nothing to calm an autoimmune attack, and it will do absolutely nothing to restore the systemic hormone loss of atrophy.
So they apply the cream, endure the burning, and see zero results. They assume it's a stronger strain, they buy a different over-the-counter treatment, and the cycle continues.
It's tragic.
The sources indicate patients can spend months, sometimes years, locked in this frustrating loop of self-treatment. They spend significant amounts of money on useless antifungals while the actual disease continues to aggressively progress, leading to more permanent scarring or deeper ecosystem collapse.
Getting out of that loop requires a physician who knows exactly what mechanism they are targeting. because the medical solutions for these two conditions are entirely opposed. You cannot treat a hormone deficiency with immune suppressants,
Right.
and you cannot fix an autoimmune disease with estrogen.
So what does this all mean? Let's break down the actual highly effective treatments outlined in the medical guidelines, starting with reversing the hormonal drought of vaginal atrophy. The mission here is to restore the water supply to the garden without flooding the entire neighborhood.
Exactly.
And the gold standard, universally cited across the clinical literature, is local vaginal estrogen.
The term local is the most important word in that recommendation.
Right, it's not a pill you swallow.
Exactly. This involves tiny, low-dose estrogen tablets, localized creams, or flexible silicone rings inserted directly into the vaginal canal. Because the hormone is delivered strictly to the affected tissue, the systemic absorption into the rest of the bloodstream is remarkably low.
Oh, that's great.
Yeah, it bypasses the liver and acts directly on those high-density estrogen receptors we discussed earlier.
And the cellular reversal is incredible. By reintroducing that local estrogen, the tissue begins producing glycogen again. The lactobacilli repopulate, the lactic acid returns, the pH drops back down below 4.5, and the mucosal thickness and elasticity are restored. It effectively rebuilds the collapsed ecosystem from the ground up.
It really does.
And for those who cannot or just prefer not to use localized hormones, like patients navigating certain hormone receptor-positive breast cancers, the sources highlight highly effective non-hormonal moisturizers.
Right.
They don't trigger the cellular glycogen loop, but they do trap moisture in the tissue, providing massive symptomatic relief. There is also emerging data on transvaginal laser therapy designed to artificially stimulate collagen production and increase blood flow without hormones.
Those localized treatments are transformative for GSM. But if the physician observes the white plaques, the figure-of-8 pattern, and the structural scarring of lichen sclerosus, localized estrogen will fail completely.
It won't do a thing.
Estrogen cannot stop a rogue immune system. To halt LS, you have to forcefully suppress the autoimmune inflammation.
The heavy artillery.
Exactly. The gold standard for lichen sclerosus is the use of ultra-potent topical corticosteroids. The guidelines predominantly highlight clobetasol propionate. This is a remarkably strong steroid.
So not just over-the-counter hydrocortisone.
Oh no, vastly more powerful than the hydrocortisone you might buy for a mild rash. It requires a very deliberate, carefully monitored tapering regimen.
You don't just use it whenever you feel an itch. The protocols demand a strict schedule. Often, the patient applies this ultra-potent steroid daily for 4 straight weeks to violently hammer down the acute inflammation and stop the immune cells from destroying the extracellular matrix.
Right.
Once the flare is suppressed, they taper to alternate days for another month and eventually settle into a long-term maintenance dose, perhaps applying it twice a week indefinitely.
And that maintenance dose is non-negotiable, because it keeps the immune system suppressed just enough to halt the agonizing itch and, more importantly, stop the relentless progression of the scar tissue.
And that leads us to the ultimate stakes of this entire diagnostic puzzle. What happens if the misdiagnosis continues indefinitely? What if a patient simply gives up, stops buying the useless thrush creams, and decides to just live with the pain, assuming it's their new normal?
This raises an important question. The long-term consequences are where the paths of these two diseases drastically diverge, and it is the most vital clinical distinction in the literature.
Okay.
If severe vaginal atrophy is left completely untreated, the patient will endure a deeply diminished quality of life. The painful intercourse and the chronic urinary tract infections will persist, but vaginal atrophy is fundamentally benign.
Meaning?
It has zero potential to undergo malignant transformation. It will never turn into cancer.
Okay, so it will make you miserable, but it won't mutate.
Exactly. Lichen sclerosus, however, carries a documented significant risk of malignancy. The dermatological and gynecological guidelines explicitly state that approximately 4 to 5% of women with untreated or poorly managed lichen sclerosus will eventually develop squamous cell carcinoma, a form of vulvar cancer.
Wow. 4 to 5% might seem like a single-digit statistic, but in the realm of oncology, that is a highly significant, completely avoidable risk.
It is. The mechanism of that risk is chronic inflammation. When the immune system is constantly attacking the tissue and the tissue is constantly trying to rapidly repair itself with dense scarring, cellular turnover accelerates.
Which creates errors.
Right. That hyperactive, chaotic environment is a prime breeding ground for cellular mutations. This is why proper clinical diagnosis, often requiring a punch biopsy, if the visual presentation is ambiguous, and lifelong steroid management are absolutely essential. The steroid doesn't just stop the itch, it actively prevents the inflammatory environment that leads to cancer.
It is a profound difference in outcomes based entirely on getting the initial diagnosis right. To pull all of this complex data into a clear, unified picture, we're dealing with two highly common, frequently overlapping, but physiologically opposite conditions. Genitourinary syndrome of menopause atrophy is an internal hormone-driven collapse of the mucosal ecosystem. It features dryness, elevated pH, and bacterial shifts, and it is expertly reversed by reintroducing local estrogen. Lichen sclerosus is an external, localized autoimmune attack. It manifests as a maddening itch, shiny white plaques, and rigid, anatomy-altering scar tissue, requiring ultra-potent steroid regimens to suppress the immune system and neutralize a very real risk of malignant cancer.
The mechanisms, the geography, and the medical interventions are entirely distinct.
And yet, they share one deeply frustrating commonality, bringing us back to the statistic we opened with. 60% of menopausal women experience these brutal symptoms. Only 7% receive treatment. When you read through the medical guidelines, you realize the science to fix this is already settled. The estrogen works, the clobetasol works, so why the massive void in care?
It's a huge problem.
The sources indicate a dual silence. Patients wait for their doctors to initiate the conversation, assuming if it were serious, the doctor would bring it up. Meanwhile, physicians are often rushing through generalized appointments, completely bypassing specific, targeted questions about genital health. But I want you to consider a deeper, more provocative thought before we wrap up today.
Okay.
Think about why this specific blind spot exists in modern medicine. If 60% of the population experienced agonizing, architecture-altering pain in their eye, or their throat, or their hands, it would be a global health emergency.
Oh, absolutely. There'd be funding everywhere.
Right. There would be public awareness campaigns. But because these specific symptoms occur on the female vulva and inside the vaginal canal, they are relegated to the shadows. We are talking about conditions that can literally fuse human anatomy together and potentially breed cancer. Yet the medical establishment and society at large are still, in many ways, paralyzed by the discomfort of simply saying the words out loud.
It's awful.
The delay in diagnosis isn't a failure of our microscopes. It is a failure of our culture to treat female pain as an urgent mechanical reality rather than a shameful, inevitable burden of aging.
The clinical tools to end the suffering are sitting right there in the pharmacy. We just have to be willing to shine a light on the symptoms and demand the correct map.
If you take nothing else away from this deep dive into the sources, let it be this. Do not normalize chronic pain. Do not accept a cycle of failed over-the-counter creams. Understand the distinct geography of your symptoms, break the silence in your doctor's office, and advocate for the precise, targeted relief that the data proves is waiting for you. Thank you for joining us as we untangled the science today. We hope we've given you the knowledge to navigate these medical complexities with confidence. Until next time, stay curious and keep asking the hard questions.